So Neil Roberts, it's a pleasure to welcome Neil, who is a consultant cardiothoracic surgeon here at Barts, and he's going to talk about they're all difficult questions, but particularly vexing is the timing of surgery and how early is early.
The AV. So early versus late surgery in endocarditis. So I'm one of the consultant surgeons here at Barts. I was at UCLH and we moved to Barts, and one of the really brilliant things that we've done is set up an endocarditis MDT, and I'm going to allude to that in some parts of the talk. But when you get a critical mass, there are things that you can do that that really do change the way that we do these bits of decision making. Sarah Fendius is one of our trainees who's helped put this talk together and do some of the research. So the controversy, I remember in my training that I saw someone ventilated with mitral valve endocarditis, severe mitral regurgitation, in heart failure, ventilated, and the consultant surgeon came around and said, 4 weeks of antibiotics, I'll see, tell me when they're better. And that was 15 years ago, and that would never happen now. And there's been a real big shift towards getting surgeons involved in the decision making early, and there is a trend towards early surgery. But early surgery is technically more difficult. When you put a stitch through hot buttery like tissue, it's not a nice thing to do, and it tends to fall apart. We think that early surgery, the sicker people are when we take them to the operating room and give them that physiological insult, the higher the mortality rate. And if you're operating on people who are really red hot and septic, are we putting valves in and with the risk of people getting late endocarditis on the prosthetic valves? And no surgeons really like redo surgery, no matter what they might say. And what do we mean by early surgery? Is it 1 day? Is it 1 week? Quite often people have had a slow, circuitous route to a cardiac surgical centre and presented in a variety of ways. So what do we really mean by early surgery? But if we do intervene early, we effectively drain the abscess, and lots of valve vegetations and infected valves behave like an abscess, slap in the middle of the flowing blood, and this treating the abscess allows us to control the infection. For aggressive organisms, we want to intervene before, so we can just do an aortic valve replacement and not have to patch the aortic root abscess and do all the things that make life more difficult. So the objective of this talk is to look at the evidence and try and tease out some of the confounders that people will think about: a recent cerebral event, a remote focus of infection, right-sided endocarditis with lung abscesses, prosthetic valve endocarditis. How do they play into the decision making? I'm not going to try and tell you what to do, but I think they're interesting points for discussion. So these are the European guidelines, and they classified the time from 2009. And they classified the timing of surgery into emergency, i.e. hours, urgent 1 to 2 days, or elective 1 to 2 weeks. And they're just big vegetations were down as a 2B in a few days, but a 2B recommendation. So just isolated vegetations were thought to be not a particularly important reason to go to surgery. Uncontrolled infection and aortic or mitral left-sided endocarditis with severe regurgitation but no heart failure was a 2A indication in the elective 1 to 2 weeks kind of timing. And then in the New England Journal of Medicine in 2012, there was a paper by Kang that really, and everyone started talking about it, saying we've got to do surgery early. It was a randomised trial of about 70-something patients. All heart failure was excluded, but these were specifically, when you read the detail of the paper, these were people with severe AR or MR with big vegetations. So going on the European guidelines, there was already an indication for an operation in a short amount of time. And they were randomised to either early surgery, so within 24 hours of the diagnosis and within 48 hours of them being randomised, or conventional therapy, which was to complete the course of antibiotics which is a little bit odd because there was already a 2A indication on the European guideline. This was in South Korea. There was already an indication to probably do an operation within 1 to 2 weeks. And interestingly, the conventional therapy group all had surgery within 2 weeks. Most of them had surgery within 2 weeks. So this randomized trial of early surgery was really 48 hours after the diagnosis or within a week. And so not as, and only 35 patients, 30-something patients in each group. The results were quite dramatic. Lots more people had primary endpoint events in the delayed surgery group, even though they had surgery quite expeditiously. But at 2 years, the results were pretty much the same. And it was this paper that the primary endpoint in the short term was quite dramatic. So it was that paper that drove people to say we've got to operate on people with endocarditis really early, and within 48 hours. And I think that's something that stuck true. But remember, these were people with an indication for surgery already. So the big confounder really is if you've got a vegetation that isn't that big and you've got mild to moderate valve regurgitation, what do you do with those people? And they're the people that it's really, really difficult to make the decision on. Can you give them an antibiotic for a week or two? Does that make them better? Should you do surgery early? And I don't have the answer to those patients yet. There was a very interesting paper as part from the French group who looked at the European guidelines in 2009 and looked at whether the guidelines were followed and what happened to the patients and what the outcome of patients were, depending on recognising an indication for soonish surgery and whether that was followed. And effectively, there was quite a few patients, 300 patients, and 220 of them had an indication for surgery, and 130 of those, surgery was performed, and in 30% of them, surgery wasn't performed. And they tried to tease out whether the indication for surgery was identified, but surgery didn't happen because there was some other confounder, too sick, too frail, comorbidity, whatever the clinical decision, or was the indication for surgery not identified? And there was a fair spread of agreement between the common indications: previous embolization, uncontrolled infection, presence of heart failure. All the groups had all those indications had a fair spread. And interestingly, the patients that had an indication for surgery and went and had surgery had the better outcome. The next best group were patients that didn't have an indication for surgery and didn't have surgery, quite correctly, and that gives you kind of a clue of those people with small vegetations and very minor regurgitant valve lesions. There probably isn't a mandate to rush in and intervene on those, despite the paper from Korea saying you've got to intervene on you've got to do surgery on endocarditis quite soon. And then the people that had an indication for surgery but weren't operated on did the worst, not surprisingly. And their conclusion was that we've actually got to really look hard for the surgical indications, and we should be more aggressive with surgery when there's a clear indication to do it. There's been quite a few meta-analyses, well, 2 meta-analyses on looking at early surgery versus conventional surgery, and it's a very, very difficult bit of literature to tease out. A group from China did a pretty good stab at it, but there's got to be a whole load of bias about people that get to a surgical centre and get operated on earlier, probably sicker, people that can wait, probably are a little bit better. But it tries to help tease out whether you should operate on people straight away or give them a little bit of time to try and get them as fit as you can for surgery. Line of no effect, straight line slap down the middle. At the top, surgery within the initial hospitalisation favours early surgery. This is the in-hospital mortality of people that are actually at the time of the index event. Within 2 weeks of surgery, a bit more favourable for early surgery. Within 1 week, short-term mortality, very favourable for early surgery. Within 3 weeks, drifting slightly more. But interestingly, for the long-term mortality, surgery within a week didn't favour the right over the line of no effect for favouring early surgery in people that had surgery within a week. And why is that? And that's probably because these people had heart failure already, were sicker, had more aggressive endocarditis. But the people in the long term who were stable enough to have their surgery in the index hospitalisation within 2 weeks, 3 weeks of surgery of presentation seemed to do better in the long term. Interestingly, at the bottom, is this on here? No. Next graph. Prosthetic. This is split between native valve endocarditis and prosthetic valve endocarditis. And prosthetic valve endocarditis is really more difficult. Overall plot sits on the line of no effect. So as surgeons, we're always pretty reticent to rush into redo operations, especially if there's an aortic root. It's not just a redo valve. If you've got to take the coronaries off, double valves, it always makes things a little bit more difficult. And there's always a bit of surgical denial in terms of trying to treat people with antibiotics first. But there isn't a whole load of evidence that going in early for prosthetic valve endocarditis is right, and that probably means that it's because of the upfront risk of the surgery. Another meta-analysis came up with pretty similar results, but they split between surgery within 20 days or conventional therapy, finish the course of antibiotics, get stability, and then do the operation. So, despite there being a real feeling that because of the New England Journal paper that operation within a few days is definitely the right thing to do, when you look at bigger cohort groups, there's probably, I'll come to it later, there's probably a 2 to 7 day window when it's right to do the operation. But exactly where in that 2 to 7 day window, I don't think anyone can be particularly sure about. And it's something that data from endocarditis MDTs is going to collect all these bits of decision making together and probably help us decide what to do. And that's when there isn't a really, really clear fistula, abscess, heart block, nasty stuff endocarditis that we all know we're going to go into early anyway. What about cerebral events? Is it safe to operate in someone that's had an embolic stroke? We worry that when we give them the 30,000 units of heparin, there'll be a hemorrhagic transformation or an extension of the stroke that they've had. So, should you wait 2 to 4 weeks, or should you do it early? And there's a bit of literature out there. This is one of them. Headline: early operation for endocarditis is not associated with worsened outcomes. So a pretty definitive headline. That's the abstract. Essentially, just split people that had an embolic stroke into surgery within 2 weeks or surgery after 2 weeks. And although the red bar is no stroke, the white bar is stroke. Within operation within 2 weeks, the stroke, although not statistically significant, the stroke rate in the people that had surgery within 2 weeks was double the people that had a stroke. So not statistically significant, but clinically probably quite important. So the headline is, you can do it within 2 weeks if there's a real strong surgical indication, abscess, heart block. Don't let the stroke stop you going ahead with an operation. But there is, although not statistically significant, there is an enhanced stroke risk for going in very early. And another paper that's essentially very similar. They said that the risk of hemorrhagic extension was actually quite small in the early surgery group, but that was after 2 weeks. So headline. There's probably there's some suggestion early surgery is safe. Clinical numbers a bit bigger if you go in within 2 weeks, but the neurological event shouldn't stop you going ahead when there is a real clear surgical indication, severe heart failure, abscess, fistula, etc. What about remote infection? And it's something that'll be interesting to hear people's thoughts on. With the advent of an endocarditis MDT, when people have non-specific symptoms, are we going to do more remote imaging? Are we going to do a few more PET scans to look for other focus of infection when we can't be really sure, when the echocardiography doesn't really tell us that the valve is the real focus of infection, and people with right-sided endocarditis are the classic of this. But what do we do when we find remote infection? Discitis, reasonably common in the staphylococcal patients, but we would go ahead and just treat with a prolonged course of antibiotics. But if there's a psoas abscess or another focus that we can drain, we'd want to do that before we put our new valve in. And again, it's something that cerebral abscess, again referring to the earlier papers, we probably should go ahead as long as if there is a surgical indication. Right-sided valve lesions, my feeling is that if you're an IV drug abuser, we've got to be really sure people are going to comply with therapy before we rush in to do an operation. The risk of embolization is for a PE as opposed to a stroke. There's a risk if we've got to replace the tricuspid valve rather than repair it. There's the whole confounder of, do we put epicardial pacing systems on? Are we going to put a tissue valve in? Are we going to leave an infected right atrium that someone's got to put a coronary sinus pacing lead in? There's quite a few confounders there. And more importantly, if there's uncontrolled infection, is that because of pulmonary abscess, or is it the lesion on the tricuspid valve that's the problem? So these patients are very difficult, and I think endocarditis MDT data is going to be the thing that informs us some more. Finally, in prosthetic valves, the redo situation really does change the risk-benefit profile. The meta-analysis data suggests the role for very early surgery is slightly less compelling, and we've got to be really guided by the microbiology and go for the very aggressive, resistant organisms where we know we have to go in and do early surgery. The chance of treating someone successfully with prosthetic valve endocarditis just with antibiotics is reasonably small. So it's, again, we probably are going to do an operation, it's just when you do it. And it's that 2 days to 2 week window that we're really not very sure about. So in conclusion, I think heart failure, hemodynamic stability, aggressive infection, severe regurgitation, abscesses, early surgery, there won't be any surgical argument about that. Without the above, despite the Kang paper, there's a 2 to 7 day window, but there is no data anywhere in the literature that waiting more than 2 weeks, pretty much under any circumstance, is the right thing to do. Thank you for your attention, Al.
Thank you very much. Any questions for Neil about surgery? Yes. Well, normal surgeons.
Thanks. Neil, the patients who worry me are the ones who are septic.
Yeah.
Because I think there is some literature to say they do particularly badly, don't they? If you operate on somebody who's got a high temperature and is relatively hypotensive from sepsis. I suppose.
But they're the people I've operated on a few of those where you put your hands in the chest and they are, it's like putting your hands into a warm bath. They are red hot. But they tend to be the people with really aggressive organisms, and they don't get better with antibiotics either. So I think there's a drift towards the sicker the person is, you've actually got less to lose surgically to some extent. So someone and they tend to have, those patients that if they're hemodynamically stable and they're on a ward with a reasonable blood pressure and on a little bit of oxygen and they're stable, then they're probably you can try and get them a little bit better sepsis wise. If they come in ventilated with a severely regurgitant lesion and heart failure, I'd take them straight to theatre. Even with the high temperature,
What would be your definition of failure of medical treatment? How long do you wait?
Well, that's the big problem, and I think a lot of this is all about the microbiology. I don't think there's a lot to gain if you're 2-3 days in, someone's had good antibiotic therapy, you're not winning. They've got an aggressive organism that we can identify. Staff, I think we've just got to go in, because there's a bit of denial, and you just don't. They don't get better. Is my feeling, and that's one of the things that we seem to be noticing. We've had a pretty early surgery strategy at the heart hospital. We went in quite early, and the ones we've waited, they just don't get better. We end up operating and they're sicker. So, but it's a really difficult call.
Quick question.
Yeah, so one of the other issues which comes up from time to time are the people with a more indolent presentation, more the old style sort of SBE presentation, who come in with an albumin of 20. And I always worry about those people, because I think, partly because low protein is a marker of a poor outcome, and there's always this dilemma of, well, do you try and get the nutrition better if they're not in heart failure, or should you just go and operate on them? My feeling is you should just go and operate on them, because you're probably not going to be able to improve their nutrition in any way before you get rid of the sepsis. But I'd be interested in your views and what, the risk, the perioperative risk of going into surgery with an albumin of 20-21 grams.
There's usually a reason for that. They're usually the kind of difficult, alcoholic, poor social class, low nutrition anyway. And again, we quite often sit and think about these patients for a while, but every time I've seen it, they just don't get. But you put an NG tube in, you try and feed them. You can't buy them the 4-6 weeks that they're going to need to really make their albumin's not going to change in a week. So it's trying to identify the things that you really can get better. Usually we can buff them up a little bit, get their fluid status a little bit better, try and improve the renal function. But just do it. I think just do it. The signal's there. The sicker they are, the probably the earlier we should go.
Great. Neil, thank you so much. We need to move on, and it's a pleasure